The technique I use for membrane peeling in P.D.R. takes inspiration from everyday life. What are we doing when we want to separate two sheets? We fix the sheets with the left hand in order to allow the right one to induce an equal tension to these two sheets and to cut in between without tearing any of them. In the eye, we have a place where the membrane is fixed to the retina without any risk for traction to induce a retinal tear. In a first situation, things are easy. There is no severe proliferation except in front of the optic disc. We will make a plan of cleavage and separate the membrane starting from the disc and then turning around it. The movements will be then centrifugal and parallel to the retinal plane. No need to use forceps or scissors, which can induce retinal tears or hemorrhage. At the end of this in-block dissection, vitrectomy removes the dissected tissue. In a second configuration, there are more severe proliferations spread out in the retroequatorial areas. We can do in the same way since we have the possibility to cut between the proliferation area and the vitreous base. When reaching the adherents, we must take care to have the hook face backward. It must slip if the adherence is too strong. It is only used to delaminate in the anatomical plane of cleavage, not to pull up the membrane. With a grasping effect as produced by forceps, we could take the risk to tear the retina and complicate the surgery. This also avoids bleeding. Look at this case where a very active vascular proliferation is bleeding each time I touch it with a sharp needle. When replacing the needle by the smooth hook which will make the delamination in the natural plane of cleavage, no more bleeding is observed. The hook is used to delaminate and breaks the adherences. From time to time, the vitrectomy handpiece is used to remove the dissected tissue from its peripheral attachment at the vitreous base in order to facilitate the manipulations turning around the optic disc. When the adherences are too strong or too difficult to dissect, as it is in the superior quadrant close to the sclerotomy, I finished the job using only my vitrectomy handpiece, controlling simultaneously with the foot pedal the cutting rate and the aspiration flow. I'm doing then as a slug eating lettuce leaves, or more exactly as a cow does when selecting a tuft of grass before cutting it. In a third configuration, the adherent proliferation is everywhere up to the periphery. There is not enough space to separate the dissected tissue from the vitreous base. In addition, the dissection between two strong adherences is dangerous because, unlike the optic disc, the retina can tear under the effect of delamination. So I reduce then the opening of the port and remove the membranes with the sole help of my vitrectomy handpiece. In fact, my philosophy pushes me not to inject silicone oil in these cases with fragile vascularization. For me, tearing the retina can then complicate very much the procedure. This way of practicing can be a little bit fastidious, even if the total procedure in these cases never exceeds 1 hour, but this is much more secure in my hands. Of course, this can only be made by using vitrectomy machines which allow simultaneous cutting rate and aspiration flow control with a specially adapted foot pedal.